At Active Life, we believe that the healthcare clinic of the future is the gym.
Everybody starts with the best case scenario in mind.
Never sell anything to anybody who is not in the market for what you have.
The only reason we work out is to create the opportunity to recover.
And the healthcare provider of the future is the coach.
And this is why you guys need to get paid well, because what you're doing is really, really hard work.
All right, Dr. Amy West, welcome to the Active Life podcast.
Thank you for having me.
It's my pleasure for having you.
Of course.
So I would love to get into a little bit, Amy, of your experience both as a clinician and your experience working with CrossFit and as a CrossFitter in general. I would love for people who are listening to be able to understand kind of who's sitting in the chair across from me right now.
Okay. Well, I mean, as far as, so I'm a sports medicine physician. I'm a physiatrist, so I'm a non-operative orthopedic physician, essentially. So I work with people who get injured, people have aches and pains, and I treat all of those non-operatively because I'm not a surgeon, so it's not my default as far as how to treat people. But being in medicine in an academic center, I have encountered resistance, and through the course of my training, to specifically CrossFit, but certain kinds of exercise programs, because it was sort of a newer thing on the scene when I was doing my training, but also people not having a really good understanding of it, and on our end, just seeing the injuries that result from it. People aren't really understanding who these people are, how they're getting injured, what the training looks like. So I've been on a bit of a crusade for the past, 6-7 years to try to sway the medical world into seeing like that it's a valid, if not a way of preventing injury, if anything, way of exercising. So it's been a bit of a challenge.
Why do you think that's such a hard ship to turn? Why do you think that I want to avoid saying the medical community isn't into fitness?
Right.
Why? Because that would be total disparagement to all of the doctors out there who are into fitness.
Right.
And I think that most of the people who are listening to this are seeking out doctors who understand their lifestyle. Why is it difficult for the entire industry to turn around and say, we're dealing with a pandemic right now that is objectively more dangerous to people who are objectively less healthy to begin with? Why isn't the focus on health? Why is that a difficult tide to turn?
Well, I think part of it is, the kinds of problems that we're faced with as physicians. So the patient population, the people that we see in clinic in general, are people who essentially come to us to be fixed. They don't necessarily come looking to fix themselves, and they don't often, they're not necessarily, they haven't necessarily come to terms with maybe why they're having certain issues. I think where that is different maybe in like a gym setting, because by the time someone's presented to a gym, they've already, admitted that something needs to be changed and have sought out someone to help them change it, and are at least thinking about putting in the work to do that. Whereas as physicians, often people are in general not as willing, or they're looking more so for some way to be fixed rather than having focusing on like putting in a lot of work to fix it. So we're seeing that right now with the pandemic. It's like, yes, there's a big problem. The people who are having the worst outcomes in general are people who are with chronic disease, obese, etc. And we can focus on that and fixing that, and which is going to require a lot of work, a lot of effort, a lot of recognition that that's a problem. Or we can look downstream at, things like to treat the actual disease once it's already hit you. So it's just sort of two ways of looking at the same problem, but a lot of it is sort of like what we have to kind of deal with up front.
Well, I mean, my perception, I'd be interested in your opinion on my perception, is that generally speaking, I believe doctors get a bad rap for doing what it is that patients come to them for by a population of people who are looking at what the doctors are doing instead of asking the patient why they went. And what I mean by that is, let's say, for example, somebody comes into your clinic and they say, I have really bad knee pain. I've had it for like 10 years. They're 50 pounds overweight. They're fairly sedentary. And when they walk, the extra weight on their body over the course of 20, 30, 40 years is causing some of their knee pain.
Yep.
They're coming to you to fix their knee pain. I believe it would be irresponsible of you to say, we're not going to touch the pain. We're going to avoid giving you any medication. We're going to avoid giving you any shots. We're going to avoid talking about how you should rest it and maybe strategize some new things, because that's why the person's coming. And if you don't help them with that, then their life deteriorates because of knee pain.
Right.
I also believe it's difficult, if not borderline impossible, for a doctor like you to have the conversation with that person about, now that you're out of pain, assuming they came back afterwards.
Right.
Let's talk about how you got in pain in the first place and what effective strategies would be to make sure this never happens again, and assume that person's going to take ownership over it.
Right.
Is my perception around the conundrum that doctors face close to accurate? Is it kind of what you look at every day?
Well, yeah. I mean, that person that you've described, that person who's 50 pounds overweight with knee pain, is like a lot of the people that I see in general. So when someone like that comes to me and I'm given 15 minutes to assess a person, get imaging, talk about treatment plans, and treat them in the office if I can. And I have to see, I'm sort of, they asked me to see roughly about 30 people a day, right? So so you can imagine having, conversations about what people are eating and, how their exercise regimens are, or even like really assessing their movement patterns in a thorough way. I can do sort of a baseline screen and say like, well, you can't squat, your ankles look like this, whatever. But I can't get into the weeds with it. I literally do not have the time. But also, most people that I see, they don't want that, right? So they're like, my knee hurts. Can you make the pain go away? Because I can't go up and down the stairs, right? And I have the tools available in my toolkit to make that happen. I can provide them with medications. I can give them injections. I like to offer those things as a way to encourage activity and encourage them putting in the work to be able to fix those problems, either in a gym setting or in a physical therapy clinic, et cetera. But 9 times out of 10, is that what the person ends up doing? No. So
an interesting anecdote to what you just described from my clinical career was we had 15-minute appointments as well. And frankly, I thought it was enough to be able to do the job that somebody comes to you for. I imagine if somebody walks in and says, I have this problem, in the appropriate cases, you already have the imaging. You already have whatever blood work is relevant. You already have their vitals. Yeah. It's not like you only have 15 minutes. You have 15 minutes and a list of information about this person.
Right.
And you're trained long enough and effectively enough and have enough experience to make a discerning decision for this person in those 15 minutes.
Yep.
Okay.
Yeah.
So I think that the first thing I want to dispel for people is that, so it's a volume model. Yes, from a business perspective, but that's not necessarily sacrificing the clinical value that you can provide to a patient in that time.
Oh, right. Yeah.
So that's the first thing I want to dispel, because I think that people have that backwards.
Yeah.
The next thing I want to look at is what you would do if you had more time. Because that's the next thing that people are going to say. Well, yeah, sure, she can do what she's doing now in 15 minutes, but what if we gave her 30, 45, an hour?
Yeah.
Would it be diminished returns for you if that time was extended, or would it be extremely valuable?
Well, it depends, right? So, another thing that we have to sort of look at in this picture is how physicians are reimbursed, how physical therapists are reimbursed. There's like very specific things that you get paid for and very specific things you don't get paid for. So, I'd like to take as much time as I could with each person, but after a certain point, you don't get paid for that. And also, the hospital system would not be happy with that either. But if it sort of had like unlimited, like didn't matter kind of situation, I mean, the way that I a lot of my training, what we did, we had a lot of multidisciplinary teams, so like when I was in training, for example, like we worked with kids with cerebral palsy, right? And they would see the physicians for certain things. There was an orthotist there was PT was there, there's people working with the, adaptive equipment, assistive devices, so the person came in, had an experience where they could get all of their needs met and speak to the different people who were handling different things, and then leave feeling like they got something taken care of, rather than come in, see me, okay, make an appointment, see that person, then come back and see that person. And then also knowing that, like, yes, I understand wheelchairs and the things that are attached to them and whatnot, but like there's someone who is specifically trained in building these things. So that person would be a better person for that person to spend time with and go over things. So, like ideally if I had like my perfect setup, that's how it would be. Like I'd have, I'd be able to take care of the medical piece, also do some baseline assessments, looking at movement and maybe deciding, okay, like this person would be a good person for you to take this a step further, and having those people readily available. But for me, me spending like 3 hours with somebody is not necessarily going to, change.
Right. Well, and that's one of the things that I think is important for us to discuss today, because that is to me where I believe the coach, in the case of an orthopedic condition, that somebody who wants to be active and wants to be a part of their own solution, comes in extremely valuably,
right,
for and with the doctor.
Right.
It's the idea that, and I'm excited to dive into that topic specifically with you. I believe that the job of the doctor, oversimplified, is to save lives. Mm-hmm. And to somebody who is 50 pounds overweight, wants to be sedentary, but wants to be able to go up and down the stairs, saving their life is the shot, is the medication. Mm-hmm. And you might not like doing that all the time, knowing that those people are,
right,
they're leaving meat on the bone, if you will.
Right.
But that is saving the life. Mm-hmm. The active person coming to see you who has the same problem, saving the life might be the medication, might be the shot, to make room for the rehab.
Right.
And that might be the physical therapist's job. That might be the chiropractor's job, whoever it is that's working there. Mm-hmm. Once that condition is alleviated from a sense of it's no longer acute, it's no longer something that is stopping them from living their life basically day to day. Mm-hmm. Do you think, better question, would that be an appropriate time for a coach to begin working with that person?
Yeah, I mean, I think you have to always like think about who is the person that be seeking out the service. So I think ideally, if I could somehow connect all of my patients with who are 50 pounds overweight with arthritis, with a coach to work with them, that would be great, because that's a great way to keep that person active and engaged and working on the problem. How many people that I treat would want to do that? I don't know. I on the rare occasion that I get somebody who's like an active person who wants to put in the work, who has the money and the time, who wants to really put in the work themselves, that's when I contact you. Mm-hmm. Right. So but if you think about how many patients I see and how many people end up getting funneled down to that process, the numbers are less, maybe like 10% of the people that I see, which is unfortunate, because I think there's a great value in it. Mm-hmm. But making that connection, I don't know how it may be somewhat difficult, but I think it's a good idea.
It's definitely difficult. Yeah. And I don't expect you and me to solve it here on a podcast.
Let's do it. No.
Let's solve the problem.
Let's do it right now.
The thing I want to make sure that, the thing I think it's most important for us to discuss is how do doctors and coaches work together?
Right.
Instead of there being this, what I don't want to say it exists regularly, but I believe that there are pockets of it, and I believe that there are more of those than less, mm-hmm. where there's almost an adversarial relationship where the coach says, the doctor's just going to tell you to stop doing it, right, take this medication, don't go. Mm-hmm. And the person should go.
Right.
Because they have a medical condition that is outside of the scope of the coach.
Right.
And then I believe that there are times when the doctor says, if you do that, you're going to hurt yourself. Don't go to the gym. Don't go to the CrossFit gym. Don't go work with that trainer. Mm-hmm. And that might be exactly what the patient needs.
Right.
I have a theory about where that all starts.
Okay.
And I think it starts with when we walk across the stage, we take our diploma, and then we take the Hippocratic Oath to do no harm.
Right.
And I think it's the lack of definition around what harm actually is.
Okay.
So I think that I'm interested in your take on it.
Okay.
I think that from my clinical days, I felt like harm was allowing somebody to do something that was going to make them hurt physically. Remember, I was in chiropractic care. I wasn't, no one was coming to me with life-threatening illnesses.
Right.
As a coach, I believe that the harm is avoiding doing anything that's scary.
Mm-hmm.
And I think that huge gray space in the middle is where doctors and coaches need to be having conversations about how does that person feel about the risk and the potential reward, as opposed to eliminating the risk of either interaction.
Yeah. So, I mean, part of that is the fear of the unknown. So I think certainly coming from the medical side of things, you know, and I'm not speaking just about myself. I'm speaking about the people that I know who I often argue this point with. So, but, you know, like I've seen, you know, I've had these conversations with surgeons, for example, who have seen a bunch of people destroy their rotator cuffs from doing, you know, God knows what, on rings, on you know, whatever. And then they say, well, don't do that because it's dangerous. Because I've seen 10 people who have done that activity and have hurt themselves. And you know, within that's like kind of a, you know, it's a very self-selecting population who end up there, right? And but the idea, I think what scares the medical community is the standardization or lack thereof. You know, not knowing when you go into a CrossFit, what does that mean? You know, from what I heard, there's, you know, one coach and 20 people. How can they keep an eye on everybody? That's another thing I hear a lot. Or, you know, they heard about a guy once who did this thing who, you know, so like, and, you know, so I come up against that all the time and sort of trying to dispel that, but also like, you know, because there is a bit of a lack of standardization, you know, it's kind of like word of mouth of like, okay, well, I even for myself to send patients like, you can go to this gym because I know this person works well with people who are older or can, you know, knows how to work with people who are, you know, have pain issues or whatever, but that's not across the board. And there's certain places that even though people that I know really well that I'd never send someone who's like in this particular population to that gym because they wouldn't know what to do. Not because they're bad coaches. They're just not, you know, I don't know what they know about that.
Well, and even if you thought this was a great gym for someone to go to, if it's called like CrossFit Blowhard, you know, the 61-year-old woman who really wants to be active, or 61-year-old man who really wants to be active but has a little bit of trepidation around it, already thinks CrossFit's dangerous. So like, CrossFit Blowhard? That doesn't sound like the place for me to go.
Right, exactly.
And I think the standardization is a huge issue. And that's actually one of the issues that we're trying to tackle. We've been trying to convince is the wrong word, but I've been having conversations with CrossFit L1, L2 staff members to ask them, do you think the education is sufficient? If it's not, how do we make it better?
Right.
And I feel sometimes like Leonidas in the final scene of 300 when all the arrows come down on him. Because I have doctors on this cliff top, coaches on this cliff top, you know, gym owners over here, everybody's shooting the arrows because they're like, no, I can do that. You should stop saying I can't do that.
Right.
And I'm like, it's not about me saying you can't do it. It's about me believing that what you do is wildly valuable, and so we should make it better.
Right.
And that to me is really where I think all the juice can be squeezed, right? How can we make all these things better? So where does the scope kind of start to blend from a healthcare provider, a doctor, physical therapist, or a medical doctor, and become the scope of a coach? And maybe you can describe what you believe the best blend should be from a physiatrist like yourself to physical therapy to coach.
Well, I mean, I think it's part of it is everybody has to sort of work together. It's not like I hand you off and then it's not my issue anymore. I think part of it is like there's a constant kind of bouncing around, if you will, of the person's problem issue because it changes and things come and go. So, I mean, for me, for example, somebody comes obviously with some kind of acute injury. I've seen some things online. It's like, well, you don't need a doctor for an injury. Just go to physical therapy and we'll fix it. And, sometimes that might work, but I think a medical evaluation is warranted in most of those cases, even if it's just kind of rule in, rule out stuff. And then, that's as far as like the medications are concerned, or even like, so in physiatry, we're a little bit more trained about how to guide what physical therapy looks like, or, we're schooled a little bit more in some of the particulars of physical therapy. It's not just like eval and treat and figure it out. It's like, when I send someone to physical therapy in general, I have a pretty good idea of like the kinds of things I want them to be working on. So, I mean, I can't say that's for all physicians, but I mean, a lot of people that I know and work with, that's part of our training, right? So, someone coming to me having an issue, the imaging, if they do need medications, is only the way I like to use medications and injections and things like that is sort of, as I was saying before, is sort of a bridge to get them more active, to get them to move more or move well, or if someone's like having trouble sleeping, if they, get to the point where their quality of life is so diminished by their pain that, really just the thought of moving is not helpful, is not, something that excites them, then, that's kind of where I come in. Certainly if they have other chronic disease issues as well. So if they're on other medications, diabetes, different kinds of inflammatory conditions, things like that need to be controlled in a medical setting. That's certainly, where I see how I fit in. And then the way I've been functioning is sort of like as someone sort of connecting the pieces for patients. So it's like, okay, well, you have this issue. So now, then I send people to physical therapy to start, coming up with a plan of like, these are exercises to do on a daily basis. They sort of like lay out the initial plan. And then once I've, in physical therapy, that's a whole other kind of thing, as far as like, I know a lot of great physical therapists, but unfortunately sometimes the framework that they have to work in is sort of similar in my sense. They're kind of can only do so much, or they're only allowed to do certain things in certain times, and their hands are a bit tied sometimes. So, and then once somebody has done that, then it's like, okay, well, how do we maintain this, or how do we take it a step further? And that's where I think the coaches come in.
So how much of the stepping over each other, meaning coaches saying, don't go to the doctor, I can help you with that, when they shouldn't. And doctors, physical therapists saying, don't go to the coach, I can help you with that, or just don't do it.
Right.
How much of that do you think is associated with a scarcity mindset?
Well, I think, it's hard to say exactly how much of it, but I do think that's a big, there's a lot of like sweeping generalizations that happen. And then that's when it gets dangerous, because, it's instead of these like broad, like, don't do that, like, and this happens a lot when people get hurt doing CrossFit, whatever that means, right? Because it's a very broad thing to say. But even the people who are saying like, don't go back to CrossFit, they don't even know what that means, right? So it's like, okay, there's very specific things in that instruction that can be taken from that. So it's like, okay, well, maybe you shouldn't be doing butterfly pull-ups at high volume right now. That's a very different message than don't CrossFit, right? Yep. And similarly, like, don't go to a doctor because they'll do X, Y, and Z. Maybe you shouldn't go to that guy or girl who told you not to go back to the gym, but you should seek medical advice from someone else, perhaps, or like, maybe that coach didn't do something well, but there's these other coaches who do stuff really well. So I think that's kind of these like very broad, like, don't do this, but do that. These people do this, but those people don't do that. Like, that's where it gets a little muddy. And then people start sort of saying, well, I'm better than that. And that's when it can get really like just dangerous for a patient, and also confusing, right? Because they're like, well, who do I listen to?
100% confusing. Do you think that it would be within the realm of appropriate for a coach to coach their client at the moment on how to ask questions of a doctor when they go? And what I mean by that is, one of the things that I ask coaches to do when they're referring their clients to doctors, which we do all the time, even when we train coaches who have clients who come to them with a problem, we say, that's not really in your scope. That's something you should be sending to a doctor.
Right.
We train them to ask their clients to speak to the doctor in a certain way. And what we mean by that is, if you go in and say, whenever I squat, it hurts my knee, what should I do? Can you check out what's wrong with my knee? It's reasonable for the doctor to say, stop squatting.
Right. Even
Even if it's not reasonable in general, it's reasonable for the doctor to say that. we train the coaches to train the clients to say, when you go to the doctor, say something like, when I squat with heavy weight, it bothers my knee. I would like to be able to continue squatting with heavy weight. Can you help me be able to do that again without pain?
Mm-hmm.
Do you think that that's something that we should do differently? Do you think that that's a smart conversation to be having? Do we put the doctor in an advantageous position, or is it a position where the doctor's now really boxed into a specific corner?
No, I think it's a good idea to equip people with tools to get specific answers, because often the people they're not, when they go into the doctor's office, they don't necessarily have, they don't necessarily convey, they don't get the answers they want because they don't ask the questions, that they should be asking, right? I do think there is it's a delicate balance though, because, this happens a lot too. It's like people come in and say, well, my son, who's a physical therapist, said that I have this and that I should ask you for that. And
like a medication or a shot, or
he said I have sciatica. That's the one I hear a lot. He says I have sciatica or whatever. You know what I mean? And sometimes it's a little like you go, well, who is this person who's diagnosing you? Like what, and the person has convinced themselves they have whatever this person, and sometimes they're not even a medical person. They're like just somebody who whatever. And then that can get a little bit of it's a little bit almost confrontational in a way sometimes to me, depending on how it comes across. So I can see someone saying like, who is this coach of yours who's telling you you have this or that, So I think it's a good idea as far as like having people just be able to explain their problems well so that they get the answers they want. And I think it's a valuable thing to do. How it comes across in a physician's office is important though.
Yeah, totally. And that for me is to clarify what you're describing there is somebody shouldn't walk into the doctor's office and say, I have pain running down the back of my leg and I would like you to give me a shot for that. Allow the doctor to make the clinical decision about what it is that you need for that. Right. And that's why I have such an issue with the commercials on TV advertising medications and telling people, if you have this, ask your doctor about this.
Oh, like, which Dr. Google comes in, strikes quite a bit.
I'm sure he does.
Yeah.
So one of the other things that I catch a lot of arrows for that I strongly believe in is that somebody should try to be excellent at the most valuable thing that they can do.
Okay.
And that any effort that they spend career-wise, trying to be competent at something else to expand their scope, to expand their reach, is not only potentially dangerous because of the opportunity cost to the customer, the patient, the client, whatever it ends up being, but is dangerous to the opportunity cost to the professional, doctor, coach, therapist, doesn't matter, because they're spending time focusing outside of where they can be most valuable for people.
Okay.
I get a lot of heat when I talk about the idea that I don't believe doctors, medical doctors, or physical therapists should be focusing on how their clients are working out, what their program design should be, what their nutrition is, unless if it's in the, hey, we need to correct nutrition in a big way fast to save your life.
Yeah.
And then it becomes somebody else's job, a coach, a nutritionist, to a dietitian, to long-term manage and provide accountability to that solution.
Okay.
What do you think of that?
Okay, there's a lot of pieces of that.
So I'll give you one to focus on. My thought is, if a physical therapist is great at post-ACL reconstruction therapy, for example, that's like they are world-renowned for that.
Yeah.
I don't think it's wise for that person to start thinking about, okay, well, how could I build a better athlete through exercise, strength and conditioning programming, and nutrition modification? Because I think that that's time that they're not spending keeping up with the ACL reconstruction rehab.
Okay.
That's a simple example to ask you about.
Well, it's a little, I mean, it's kind of hard to say exactly. So, I mean, I guess if you look at, I guess it depends a little bit about like where you're practicing, like what's the clientele that you have access to, because in certain hospitals, so for example, like I did all my training in Boston and at Harvard, and they have like, everyone there is super subspecialized. I mean, you want to find someone who can either like whatever the field is medically, you can find someone who does just that thing.
Meaning if I went to Harvard University Medical Center, I could get an endocrinologist who focuses on thyroid issues, and that would be my doctor for my thyroid.
Thyroid issues in men your age. Yes. Like, but like seriously, like you can pinpoint, like the hospital system, they're so vast that you can find people who are so super specialized, and they're world renowned in this thing. They publish on this thing. They're very hyper specialized. When I came here and the health system working, although it's a big health system, it's just different. And I don't think you can have a practice that just sees that, because it's just not, you have to see more of the general things to whittle yourself down to that like minute population. Right. So I think that's part of it. It's like where you are and who you're seeing and who you have access to. I do think I guess you could sort of look at it kind of like CrossFit training in a sense, right? I mean, you can be the best Olympic weightlifter there is, and there's a place for you, or you can be really good at that and like really good at gymnastics. You'll never be the best at either, but would you rather be able to do both of those reasonably well? I don't know. I think it's more of a personal thing. I think someone who's seeing just ACL injuries or ACL rehab might get bored with that if that's all they're doing every day, all day.
For sure.
I don't know.
I think if we use the CrossFit coach example and bring it back to the doctor, I agree with you. Where we might diverge, and I'm okay with that, I'm curious, is I believe that a gym that promotes, for example, whether you want to go to the CrossFit Games or just get off the couch and live an active life, we can help you.
Okay.
I think, that's true. You probably can. But if I want to go to the CrossFit Games, I'm working with a coach at Brute Strength, a training think tank. I'm working with a coach who specializes in helping competitive athletes become world-class competitive athletes.
Got it.
If I'm sending my father to a coach, or my mother to a coach, I'm not sending them to the person who helps world-class athletes become world-class athletes. And I'm also not sending them to the gym who believes they can help both.
Right.
I'm sending them to the gym who says, if you are somebody who is frustrated because the life that you're living is limited by the way that your body looks, feels, or performs, we have a process to help you get the results that you want.
Yeah.
I think that when there is, of course, all of those people need to be able to teach somebody to squat, to hinge, to carry, to rotate, all of those things. They all need to be able to do those things. I think it's understanding the client's needs in that case, or the patient's needs in the doctor's case, where it becomes the question of the valuable scope, not the available scope, the valuable scope.
Yeah, I'm trying to think of, certainly I think there's part of it that I would imagine as like a gym owner, having to necessarily choose, do you want to deal with athletes or do you want to deal with people who are maybe not as athletic, who are a little more on the kind of rehab spectrum? I can see perhaps you'd have to market them very differently, or have separate spaces, kind of under the same roof maybe, but in separate spaces, or, the marketing will have to look different and things like that. So I think you can have a shared, like, be under one umbrella, but then have very different, like, focuses based, foci based on, like, who's working with you. So, I don't know. It's kind of, I think so, the what you're saying before about, talking about like physicians like working on like nutrition and like programming or like workout programming and stuff like that. I think it's important, not necessarily that, I think there are a lot of physicians who are doing those things, who are, looking at people's nutrition, trying to get them on plans. Again, it's like not many people, want to take the time to do that with the physician. So, but the people who are there, I know, like, for example, there's a guy down in Dr. Siskron, Tom Siskron, who's down in Louisiana, and he's a urologist, and he was seeing all these people with diabetes and he was just like, I'm going to, fix everyone's diet. And all of a sudden, all of the urologic problems were solved too. And that's what he does, But, there's people like that all over who are doing stuff like that. And then also as far as like programming and like, I think it's important for physicians if they want to be treating, people who are working out to understand what that programming looks like. Maybe not like be taking it apart like piece by piece, but like have a good understanding of what someone's doing. So like they can say, well, maybe like have suggestions that maybe that they can bring to the coach of like, well, could you maybe like, lower the weight on this or try this, range of motion or whatever, like make suggestions in an educated way rather than saying like, don't do that or do this, because they just don't really understand it. So they just say, well, stay away from it. It sounds dangerous.
Well, and that's where I think the most value is. I think the most value is there when there's a collaborative relationship between the coach and the doctor, whatever kind of a doctor it is.
Right.
It's where I think that the doctors run into trouble, for lack of a better word. It's the wrong word. I don't have the right one in my head. Okay. Where I think doctors could be better served, I guess, would be instead of writing the squats, the running, taking into account the metabolic conditioning, the energy systems, did I hit all the joint actions? Am I appropriately loading different planes? And all of the things that a coach needs to be excellent at every day. And then on top of that, handling how did that workout feel today? Are you having stress at work today? We should change the workout based on the stress you had today at work. Those are the things to me that I think separate the everyday coach from the great coach. And I think that if the doctor dives down the path of, I want to do the things that a coach can do, it becomes very difficult to be both a great coach and a great doctor at the same time. At least until what they're doing as a doctor, I'm going to use the wrong terminology again, but goes on to some autopilot. Okay. Where someone walks into the clinic. I remember someone would walk into my clinic with an antalgic lean to one side, and you can't say, you're having a disc flare up, I'm not going to touch you today. Go home, come back in 10 days, and we'll talk about how this happened. They need to sit down and talk about it and tell you what it was. You need to examine it.
Right.
I think that, I don't know how I got to that, but I'm getting lost in my own words here. So it's the idea that I think that it becomes difficult for the doctor to go ahead and be able to do that really well. I know where I was going. Yeah. I can see the disc thing. So now I can start thinking about, like, I know what a disc injury looks like and presents like. I don't need to study what a disc injury looks like or presents like more than a few hours every few weeks because I want to be updated to things. But to catch up to the coach who's immersed in coaching, I think becomes difficult to do at that point.
Well, I mean, it goes both ways, right? I think it's, we don't do the same thing. But I think we have to understand what the other person's doing. You know what I mean? So, and not like downplay it or demean it, So, as far as like a physician, like I can't be assessing someone's workout day by day and asking them how they feel today and how can we adjust and stuff like that. Like, I see people once every, few weeks or whatever. So that's not, it's outside the scope of what I do, but I understand the importance of that and I value that and finding, and then having someone in the community who is keeping on track of that so that then we all like work together so that person gets the treatment they need, I think is how, I think that's how that works. But
may I share with you the rules that we give to the general coach who we educate to determine if working with a client is in their scope or if that client is truly a patient at this point and it's out of their scope?
Okay.
I would love your feedback on our rules for that. First things first, numbness, tingling, burning, weakness, refer out. Yeah. Those are absolutely
sounds
outside,
right.
outside of your scope. Organic conditions, meaning somebody's dealing with regular headaches, somebody is losing vision, somebody is dealing with nausea, intense pain inside their body somewhere that's not reproducible through physical activity.
Okay.
Refer out.
Yep.
That's not in your scope. When it comes to somebody who is dealing with aches or pains, the way that we teach them to make decisions is is that pain less than a 5 out of 10? Meaning, is it a 4 out of 10 or less that the person is dealing with?
Mm-hmm.
If the answer to that question is yes, we ask another question. Does the pain get better or worse as you use the body part that is in pain? If the answer to that is it gets better, then we ask another question. If the answer to that is it gets worse, then we refer it out.
Mm-hmm.
The next question is, if you're not experiencing any discomfort or increased discomfort when you use it, but 24 hours to 48 hours later, is there a focal increase in symptoms? Yes or no? If the answer is yes, refer it out. If the answer is no, you're probably not doing damage to a soft tissue or to a joint, given those 3 answers in a row.
Okay.
The fourth question is, did I ask 4 questions? I think I might have.
Yeah. It's kind of 2 and 1.
Yeah.
Mm-hmm.
Those are the questions that we want a coach to ask before deciding if they can help somebody at all.
Yeah.
The last thing we want them to know is, if somebody tells you I'm feeling this, whatever this is, do you have to put your hands on them to change anything? If you have to put your hands on them, refer them out. I don't mean cueing. I mean, are you tempted to do massage? Are you tempted to scrape something? Just don't.
Yeah.
Refer
That's
that
a good
out.
idea.
Yeah, just refer that out. And the last thing that we want to make sure that they understand is, do you know exactly what you would do next if? Whatever the answer to the if is. What I mean by that is, if I'm working with you, Amy, and you're my client, and I'm pressing with you, for example, you have some discomfort in the shoulder, but you press and you get like a sharp pain in one of those presses.
Mm-hmm.
Do I know what I would do if that happened? Meaning, would I know to shut down that set? Are we trying again? Are we lowering the load? Are we changing the range of motion, changing the implement?
Yeah.
If you don't know the answer, refer it out.
Okay.
It's kind of like, if you're going to cross the street and you're deciding, I don't know if I'm going to make it or not, just stay on the sidewalk.
Yeah.
Those are our rules for helping coaches decide if somebody should be a client or if they should be a patient first.
I mean, I think that all makes sense. I think it all is very reasonable. I think in practice, though, I think sometimes that gets a little lost.
For sure.
I've seen it happen with, someone's like, oh, I'm watching this from afar, but like someone's like, oh, I can't do a box jump because my knee, and then like coach goes into diagnosis mode, and it's like, I don't think that's right, but keep staying out of it. That kind of thing. I think that's when it gets a little muddy. But yes, I think those questions are appropriate and make sense. And
so,
yeah,
how would, I'm asking selfishly,
mm-hmm.
how would we improve the way that we ask the questions or the questions that we ask to keep a coach from, somebody says, I can't jump up in a box, and the coach says, all right, let me diagnose your knee problem. Because they shouldn't be doing that.
Right.
It should be, do you have the requisite range of motion to jump on the box? Yes. Do you have the athletic expression to jump on the box? No. Okay, I can help you with that. Yes. Okay,
right.
Then I don't know why you can't jump on the box. I'm going to refer that out to find out why that causes you so much pain.
Right, and I think that's the key is sort of recognizing, like, I'm not going to try to guess my way out of this, or even like educated guessing is in some cases is not appropriate in that setting. Like, oh, I think you have, I've seen this. Oh, I think you have some tendonitis. Take this lacrosse ball and go over there and work it out or whatever. That's for that line that gets a little bit dicey. And it's maybe you're right sometimes, but sometimes they're not, and then that can be kind of an issue. So, I think as far as when you, I think you kind of encompass that in the questions, but it's like if you find yourself suggesting an intervention, like grabbing a lacrosse ball and trying to do stuff, then it's like at least present it to the person you're talking to as if like maybe you should be having this checked out as well. Like this is just, I'm off some help, and this may help you, this may not, but this could be a bigger issue, and you need to see a medical provider for that. So I think it's like part of it is just sort of making it clear to the person who's asking you that this is not my expertise necessarily, or recognizing that it's not your expertise necessarily, and saying that, and then saying like, I can offer these things to help you, but here you might need to see someone else, so
Another thing that we see coaches run into that, frankly, I struggle to help them with is my client came in with these MRI findings. And the doctor said that they're okay to work out, right? Or the doctor said they need to be careful when they work out. My initial response is, I almost wish you didn't see the MRI findings.
Yeah.
Because there is so much unconscious incompetence around trying to interpret MRI findings without specific training to do so.
Yeah.
I mean, I graduated my clinical education and still personally was like, I will have a radiologist review any x-ray, any MRI finding, and tell me the implications thereof, and then discuss with them or discuss with the orthopedic consulting what the history was, what the presentation was, before I make any decisions about clinical care with this patient.
Right.
I don't think coaches should be messing with MRIs at all.
No.
So what happens when a patient of yours or a patient of a doctor's comes into a gym and says, hey, I have these MRI findings. What does that mean for my workout? What does the coach say? I have no idea. Ask your doctor.
Yeah, I mean, that's not a question that should be posed necessarily to, or that broad of a question should not be posed to a coach to answer.
So how does the coach help the client and CYA for themselves?
Right.
Because it's the responsible thing to do, not because you're worried about being sued.
Right.
What is the right thing to do in that situation?
Well, I think part of it is, when you're talking specifically about like MRI findings, like you said, I mean, sometimes they don't mean much of anything. So
it's a whole podcast.
Right. Yeah. So like, taking out pieces of MRI findings, it can really get complicated and tricky. So I think part of that is like, yes, that's nice that you have that MRI, but I think the coach has to be equipped with questions, sort of ask questions back a little bit of the physician. Like, this is what I want to know from your physician about these findings. What does this mean for, whatever activity they're doing? Like, what are their limitations regarding the specific activity? It's like when I give a physical therapy prescription, like, there are precautions on there if someone can't do this or shouldn't do that. And it's my responsibility to provide those. I don't just like, here, you figure it out, therapist. Like, if I know something that is definitely yes or no, then I have to spell that out, and the physician has to do that, or a physical therapist for that matter, if that's the person in the next person in the chain that's kind of the go-between. But it shouldn't ever be like, here's all this stuff wrong with me, coach, figure it out. Like, that's a little bit beyond the scope of what your training is. Also, it's not necessarily fair to you to have to figure that out, because you can really kind of get yourself in trouble with doing that.
I think it's way beyond that. And I think that there is a degree with which coaches can be educated, and I think that this exists on both sides of the spectrum. I think it exists for doctors too, where they go from being valuable to being somewhat dangerous. Yeah, I think it's more of an opportunity cost when I believe a doctor does it for the patient, meaning they may not get the outcomes that they're looking for from their fitness or from whatever the next step in their thing is. From the coach, I think it's a much more dangerous situation where you could create significant injury, significant damage that you never had a place talking to a person about at all.
Right.
So where does this all bring us to? How do we, I think this is solved when good, responsible, diversely educated doctors like yourself create relationships with good, diversely educated physical therapists and chiropractors and the intermediary.
Right.
Create good relationships with diversely educated and valuable coaches, where there can be a collaborative effort. And frankly, I think that anything else that we would talk about is how we give the industry the cortisone shot today,
right? Yeah,
to make space for that to happen.
Right. I agree. Yeah, and I think that's I think part of it is like you were saying, finding the people in your area who are doing things that you are interested in, or or working with the same population that you work with, and so that's part of it. Just like creating the the network in the community to try to find people that you respect and, who you think would be appropriate to kind of work with as far as like sending patients to or, connecting with. Sort of on a bigger scale, I know that's something that in the CrossFit health world, whatever that is these days, it's a little bit tricky, but that we have been sort of striving for, especially now, is sort of like getting like a database of, getting this database of physicians who are kind of, like you were saying, like educated and, want to work with coaches in the community, creating that network, and then, connecting that with, local coaches who are, trained kind of, like with your like lines of thinking essentially. So, we're working on, on a bigger scale, we're working on making those connections, but on a smaller scale, it's like doing things like this. It's like, I think how we sort of kind of came across each other anyway is like, through like, we know a lot of the same coaches and like social media, and we sort of like had always like been like in parallel circles, and it was like a matter of just making those connections. So, that's sort of the cortisone part of it, as far as like how to make that more formal.
Right. Well,
I'm working on it.
I think the reason why you and I ended up connecting is because we prioritize connecting with people who would be valuable to connect with.
Right.
And the time was right, and we crossed paths in a way that we actually formalized a relationship where I text you text me, we can call each other. Yeah. How does let me backtrack 1 second. I believe it's imperative for every gym and every coach to have in their back pocket the doctor who they trust, who they can, without any reservation, say, I would be happy to have even my healthiest members go see this doctor to find out what's going on, so that this doctor can provide me with more information, because more information is better, so that I can best serve them.
Yep.
How does a gym, a coach, let's call it a fitness professional, start a relationship with a busy doctor? Because let's be honest, if a doctor is doing the right things like you're describing, they should be busy. How does that gym owner, that coach, get in front of that doctor, demonstrate the value in such a way that it is enticing for you to have a relationship with them?
Well, something that I think, through working with the CrossFit Health community, what we sort of realize is that there are quite a few of us, as far as like physicians who are interested in fitness, who are, aware of the CrossFit methodology and are interested in working with that population. And so a lot of boxes, or gym facilities have physicians in them already. You might not know that. They might not,
within the membership base.
Yeah, within the membership base. So I think connecting with those people is a start. Is because then they are connected with other people just professionally, even if they themselves are not the people to be the direct kind of contact. So I think that's really important. Finding, local, certainly like in the orthopedic realm, there are, physicians that work with teams, physicians that are involved in all kinds of activities. So then it's just a matter of, approaching them, because at the end of the day, like, physicians want referrals, so they're not necessarily going to be like, go away, I'm too busy for you. Like, and if they do, then so be it. But like in general, like, people would at least be open to a conversation and be like, this is what I have this pool of people who with musculoskeletal issues, will you see them? Like, I think I don't think anyone's going to turn that down. But as far as like finding people that are kind of like-minded, I think a lot of it is within the membership base. You at least have the foundations there to at least have those people connect you with other people. So
I think that's really good advice. Go to your membership and say, is there anybody here who does what it is that we're looking to partner with? Yeah. And go from there.
Yeah. And you can always like test it out too, as far as like having people like, like inviting someone to do like a talk at your gym or something like that, just to see if that's, if they're kind of on the same page, I know personally, like we were talking about before we started recording about like all the gyms I've been to over the past like even like year or so. But I've been to a lot of different gyms that I've frequented, and there are some places where my role as physician is valued, and people kind of seek out advice or, they ask me about things. And there's some places where like, I don't even know if they know. I don't think they care. And, that's fine. But it's kind of a big loss, I think, on both our ends for them not to know that, and not because there's, lots of ways that I can, we can help each other out. But if they're not really invested in finding out that information, or if they don't even see the health space as a space for them, like, okay, well.
Yeah, I think what that comes down to is you need to be prepared to be the giver without asking.
Yeah. Meaning
if I come to your clinic and I say, hey, I have a bunch of people who are extremely active, and because of the amount of activity that they're doing, there's just going to be injury. It's inevitable. We're pushing the margins of their experience. I'm looking for a place where I can send them, who I can have open dialogue about the people who I'm sending in, to learn about what's going on with them and what we need to do when they come back into the gym next time.
Right.
Can we have a conversation about you being that place? Is that something you'd be interested in? I don't think many people are going to turn that down.
No, I doubt it. Yeah.
It becomes when the gym owner or the coach, to me at least, I believe, says, I'd like to send you all these members of mine who are dealing with pains. In exchange for that,
right,
you're screwed. It's over. Stop.
Yeah.
So last question I'll ask you is, do you believe that it's valuable or even pushing it to necessary for fitness professionals to use assessments to guide the way that they design their programs and structure their workouts for their clientele? Or do you think that assessment within the process, meaning like, I'm watching you squat and your squat is limited, so we're going to change that on the fly example?
Well, what kind of assessments do you mean as far as like?
A basic, for lack of a better term, orthopedic assessment. So a trainer being able to identify not, your labrum, this rotator cuff muscle. Can you reach down and touch the floor? Can you get your hips into the position you're looking to squat in? Can you get your arms over your head before we put you on the pull-up bar? Do you have ankle range of motion so that when you squat, if you tilt forward or fall back, we can rule in or rule out the fact that it may be your ankles? That kind of assessment.
No, I think there's a role for that. And I think, it's like any assessment, whether that's that or it's imaging or whatever, it's like knowing what you're going to do with that information once you have it. So if a coach is able to, look at those sort of sound like very basic kind of assessments of range of motion and whatnot, and then is prepared to deal with the results of that, then I think it's a good idea.
Okay. Yeah. Your podcast is Docs in a Box.
Docs in the Box.
Two docs, DOCS.
Mm-hmm.
What do you guys talk about on that show? I was a guest, and I appreciate that.
So it's myself and my friend Dr. Matthew Cowling, who's also a physiatrist. He's out in Wisconsin. And essentially we talk about we met through the CrossFit Health thing. We met at one of the first MDL1 seminar. And through the CrossFit Health space, we've met many interesting people who are doing very interesting things, either in the world of fitness, in the world of medicine, sometimes in both. And also we have made many connections sort of within the CrossFit space with, people who are sort of doing all kinds of interesting things all over. So we thought, like, let's talk to these people and let's make other people aware of what they're doing. So, so we talk about, what we have different guests on about, talking about what kind of interesting things they're doing and how they're mixing the worlds of medicine and CrossFit and fitness in general. So
I think it's very cool. And I think that it's, when we speak as a company, when I speak on behalf of the company, there's a lot of stuff that I would love to be able to nuance more in the message. That becomes very difficult because everybody feels like they fit in the nuance.
Yeah.
So for example, if we said 99% of people need to whatever. Yeah. I would imagine 99% of the people who fit in the 99% believe that they are now excused and they're in the 1%.
Yeah.
And I appreciate you coming on the show and talking to me about the gray space, the nuance between the absolute rules and the exceptions to them. Because I know that there are many exceptions to every rule. And anytime that you speak one, I speak one,
Yeah.
Everybody who is the exception takes exception.
Right.
And personally, I appreciate that.
Mm-hmm.
I appreciate that they take exception to it because it means that there's pride in what they're doing.
Mm-hmm.
And I have immense respect for that. And I wish there were more people like it.
Yeah, I think part of the, certainly in our CrossFit physician community, I think we've experienced a lot of, as physicians in general, I think we've experienced a lot of people taking shots at the profession from different angles. And especially for those of us who are, I guess you would say kind of woke to the fitness mindset and that, it's particularly painful because we do, our training is extensive. We're all very dedicated to our patients. We all support, people being healthier and want to help people get to that space. I do think sometimes we're kind of constrained by the system, if you will, and what we have to do and what we're paid to do versus what we, the kind of experience we'd like to provide for people. And I think, we've, I know some of us have sort of encountered people saying like, they don't know what they're talking about, or, kind of poo-pooing the doctor's experience, but also, knowledge of a situation. So I think that I think everyone just wants to be like respected, and everyone wants to just kind of, and ideally work together. I think that's what I envision as going forward is something I'd like to see is a lot more collaboration and a lot more just like everyone respecting what the other person brings to the table and then working together to kind of make the patient experience better, which is, there's many steps in that process, but I think this is like the start of it,
I hope so. I think that more questions and less assumptions leads to better relationships and ultimately better outcomes.
Right. And certainly in the orthopedic space, because I think there are a lot of people kind of in parallel to the musculoskeletal realm of things. So, there's the orthopedic surgeons, and there's people like me who are non-operative. Then there are also, like the chiropractors, the physical therapists, the coaches, you name it. There's a lot of people who have their hands in the pot. So, it's just kind of recognizing where we all fit, and that it's not like this or that. It's like we can all just work together. And I think that will be ultimately what makes people, their musculoskeletal health, what improves their musculoskeletal health the most.
Yeah, I agree with you. And that's a big part of the reason why, and I can always improve my own message. That is a big part of the reason why I think it's so valuable to the general public to have coaches who have a very clearly defined scope, because right now there's a lot of gray at the end of their scope. Physical therapists and chiropractors who have a clearly defined scope, because right now there's a lot of gray at the end of that. And doctors who have a clearly defined scope, because I think that there's a lot of gray around that. When I say doctors, I mean at that point medical doctors and all the varieties they're in, DOs, all of it. Because I think that, again, it becomes a decision fatigue. And if everybody knew, if I have this problem, I go to this person, and this person is going to take incredible care of me when I'm there. And as soon as I have this problem, that person's going to collaborate with this person on solving that one. And as soon as I have this problem, they're all going to collaborate. I think we'd all be in a better place.
Oh, for sure. Yeah. Ideally, that's what we want to happen.
So I would love to have you back on again and talk about some of the stuff that you talked about that I really wanted to dive into, but I felt like there were better things to talk about on this show. And those are issues around pay, and time.
Oh, yeah. Yeah. Oh, for sure.
Thank you very much, Dr. Amy West.
Thank you for having me.
I hope you enjoyed this episode of the Active Life Podcast. If you did, please be sure to head to wherever you listened to it and give us a quality review, as well as 5 stars if you can spare them. If you want more from us, feel free to follow all of our social media accounts at Active Life Professional, Active Life RX, and Dr. Sean Pastuch on Instagram. Remember, at Active Life, we believe that the healthcare clinic of the future is the gym, and the healthcare provider of the future is the coach. We also believe that future is